is the RAAS in the story of diabetic kidney disease. As we know, the RAAS has been discovered about one century previously by Professor Joseph and Rupert, and they have described a substance known as renin because it is produced by the kidneys as has a pressure effect on the vessels. What is the role of the kidney support? She had three kidney functions in glucose regulation. Number one, production of glucose in the renal cortex, responsible for about 20-25% in the process of gluconeogenesis. It is responsible for utilization of glucose in the renal medulla, about 10% of utilized glucose, usually for energy production to maintain kidney functions, and reabsorption of glucose in nephrons, which is usually advocated that the usually glucose filtered 180 grams per day will be reabsorbed again. What is the role of aldosterone and angiotensin II actions on insulin metabolic signaling? As we know that the cell will take the glucose and the insulin will enter for this glucose utilization. It is very important that the insulin helps in renal glomerulus. For podocytes, maintenance of structural integrity, decreased apoptosis and energy utilization. For the capillaries, increase nitric oxide bioavailability or increased angiogenesis. For the mesangial cell, maintenance of structural integrity and of course mesangial cell expansion. But here, usually, the mineralocorticoids such as aldosterone and angiotensin II usually have a suppressive effect on this, what's known as insulin metabolic signaling, with the process, of course, of impaired insulin function and the diabetes inside the kidney. So that, what is the role of renin angiotensin? Angiotensin is produced by the liver. So renin is secreted by the kidney. It converts angiotensin to angiotensin 1, and the ACE produced by the lung will convert angiotensin 1 to angiotensin 2, which increase sympathetic activity and of course increase blood pressure, tubular sodium chloride reabsorption, and responsible for stimulation of aldosterone, which also helps in sodium reabsorption, and it has direct arterial vasoconstrictive effect with increase in the blood pressure and increase ADH and increase thirst sensation, so that it will make salt and water retention, which may lead to, of course, increased volume overload and hypertension. But rather than these hemodynamic effects, also angiotensin II, through its action on angiotensin 1 receptors, it will activate inflammatory cytokines, of course, vascular smooth muscle growth, oxidative stress, endothelial dysfunction, increase the plasminogen activator inhibitor 1 activity and thrombosis, with of course the inflammatory cascade and the profibrotic process inside the kidney. So that angiotensin is very deleterious. It will induce the active oxygen species, will play glomerular hemodynamics by vasoconstriction of the efferent arteriole with increased intraglomerular pressure, induce apoptosis, hypoxia, proteinuria, growth of glomerular and tubular cells, of course, which is very important for glomerulosclerosis, inhibition of nitric oxide synthesis, tubular transport, and of course stimulation of extracellular matrix with increased tubular HDL and albumin uptake, which of course is nephrotoxic, abrogation of toll-like 4 receptors, which here induce the inflammatory process, induction of chemokines. So that the end story of this process, that angiotensin II plays a central role in organ damage. On the vessels, atherosclerosis, vasoconstriction, vascular hypertrophy, endothelial dysfunction, which will lead to hypertension and of course cerebrovascular events. On the heart, LVH, fibrosis, remodeling, and of course may produce heart failure and MI. On the kidney, reduction of the GFR, increased proteinuria, and increased aldosterone release, glomerulosclerosis. What is the play here? Hyperglycemia usually increased production of angiotensin II in glomerular mesangial cells. This is the whole story, or the main story that we should here emphasize upon. That hyperglycemia is not hyperglycemia only, but it will increase production of angiotensin II in glomerular mesangial cells, so that with the whole process and all deleterious effects of angiotensin II receptor stimulation. As you can see, when you have angiotensin II here inside the glomeruli, it will produce vasoconstriction of efferent arteriole with increased intraglomerular pressure, long-standing glomerulosclerosis, and hyperfiltration, as we can see in this process. This is the angiotensin II have hemodynamic effect and non-hemodynamic effect, and aldosterone here to complete the system of the RAAS system in this process by increasing proteinuria and sclerosis and fibrosis, and of course deterioration of the kidney functions. So that this is very important to start the process of RAAS blockade. We have 4 types for RAAS blocks: direct renin inhibitors such as risperidone, ACE inhibitors, and ARBs that inhibit angiotensin II-1 receptor, and of course mineralocorticoid antagonist which acts on antagonize the aldosterone receptor such as spironolactone, epinephrine, and the new player which is finerenone. As we know that there is different mode of action between the 2 drugs. ACE usually here making blockage of the angiotensin I receptor and increase bradykinin, which have also several effects, while angiotensin II receptor here blocks only angiotensin I receptor and with more stimulation of angiotensin receptors, which has anti-proliferative and inhibitory effect on the growth of cells and helps apoptosis. Very sophisticated area. It is not, of course, the story of our lecture today, but this is our target to retard the progression of diabetic kidney disease through, of course, control of hyperglycemia and obesity, podocyte injury, and reduce endothelial injury, and here improve, of course, hemodynamics, reduction of albuminuria, reduction of fibrosis, inhibition of inflammation, of course, the stress, the bioenergetic exchanges, oxidative stress, and epigenetic modifications. If you have blocked all these players, you may help in retardation of the progression of chronic kidney disease. And as you can see, most of them here, the RAAS, of course, system blockers and the mineralocorticoid antagonist may play a role in this process. ACE have become a very important cornerstone. After the HOPE study, which is the Heart Outcomes Prevention Evaluation Study, this trial confirmed beyond a doubt the cardiac and renal protective benefit of ACE inhibition and extended the patient base in whom ACE inhibition has been proven effective. And they have called that the idea of sacred cow refers to something that cannot be interfered with or harmed in any way. من بعد الهوب ستادي ما حدش يقدر خلاص يهوب ناحيه الايس، وحتى سموه البقره المقدسه. حاجات مش ما بقاش حد يقبل ان حد يجي يهاجم الايس، and it's very important role for protection of the heart and the kidney. So ever since the HOPE study كانت اول نقطه تحول حقيقيه in this process published in 2000s. ACE have become a sacred cow، بقره مقدسه، and nobody dared to say anything against them. ومن ساعتها بقى medications aimed at inhibiting the RAAS have been used extensively for preventing cardiovascular and renal outcomes in patients with diabetes. طبعا اتعملت دراسات كتير جدا. العواميد المهمه كانت الدراسه بتاعت 1993 هي الكولابريتيف ستادي، واللي بينت هنا ان الايس كان reduce albuminuria and retard the progression of deterioration of the GFR. وهنا جت الرينال ستادي، انا بقول الميجور ستاديز، وكانت هنا على الاربز لوزرتان، وبرضه حصل improvement of the proteinuria and retardation and stabilization of the GFR. After that came the prime program including ERMA2 and IDNT study. الERMA2 كانت في early process which is the prevention of the progression of microalbuminuria towards macroalbuminuria, and IDNT study that showed that they have delayed doubling of serum creatinine, stabilization of the GFR, and laid the way to end stage kidney disease. And this studies was done on the erbizartan, which is ARBs. Come after these studies, the Marvali study, which is very important study, have proved on valsartan that it's very important to prevent microalbuminuria. After that, they have tried, why not use both ACE and ARBs, and this was addressed by several studies. The commonest is on target study that have here reassured that the effect of ARBs not inferior to ACE, but dual combination is deleterious because of hyperkalemia. And the RECO study is very important study, which is the long-term impact of renin angiotensin system inhibition on cardiorenal outcomes. This study showed that there is no any difference regarding the effect of ACE on ARBs on the long term on cardio protection and renal protection, but ARBs may have lesser side effects. But another meta-analysis have been done and showed that ACE inhibitors and ARBs are the same regarding neuroprotective effect, cardioprotective effect, but ACE have, of course, reduced the overall, in this situation, mortality rate. But other studies and meta-analysis showed that there is no difference between ACE and ARBs regarding their cardioprotective and renoprotective effect. And here another meta-analysis have shown that both of them have the same results regarding cardioprotective and renoprotective effect. Here, Bardo, another meta-analysis shown that ARBs is not more superior than ACE regarding their beneficial effects in cardioprotection and renoprotection. But some studies showed that ARBs may be of a lesser fewer side effects because it doesn't increase bradykinin release. Here are the major studies that helped in this situation. Studies advocated to ACE inhibitors, such as the collaborative study group, captopril, RIN group, ramipril, and the ASCII group also ramipril. The other studies which was very important to prove the efficacy of ARBs, the RINALI study on losartan, IDNT study, irbesartan, roadmap study, olmesartan, and venifro, this study also was olmesartan, and they were and valsartan here in this study, and they were very beneficial. Other studies support that, such as Morris study, Willis study, EMS study, Holler study, Hurst, and Vijakama study. All of them, they have proven that ACE and ARBs are very effective alone as a single agent for management, of course, of diabetic kidney disease. There is an era, several studies, they are trying to prove us that dual combination is much better, but another studies have broken this theory, such as the IMPROVE, the SMART, the CONSE study, on target study, and Karitataki study, and AVOID study. The history of this study, that the first study on ACE was 1977, and 1999 was proving the effect of ACE. 2003, the cooperative study, here dual therapy better than monotherapy, but Kidugi 2004 have broken this theory. So that angiotensin is a double-edged sword, as we know, because it can produce AKI and hyperkalemia. The KIDU guidelines have recommended that we should use ACE or ARBs in patients with diabetes mellitus, hypertension, and albuminuria in CKD patients. CKD even without diabetes and albuminuria is the drug of choice. Of course, diabetes and albuminuria, of course, the drug of choice. And in cases of diabetes and not diabetic patients, with reduction of the GFR, of course, ARBs are very important. The new aspect of aldosterone, as we know that aldosterone is very important to prevent myosclerosis, tissue fibrosis on the heart, ventricular hypertrophy, cardiac fibrosis, and on the vessels endothelial dysfunction. So that the mineralocorticoid receptor antagonists have helped in protection against sympathetic nervous system stimulation, nitric oxide, endothelial dysfunction, fibrosis, apoptosis, inflammation, and of course glomerulosclerosis and mesangial matrix expansion and tubular injury. Not only that, not hemodynamically, but mineralocorticoid have pro-inflammatory cytokines and pro-fibrotic cytokines, so that these oxidative stresses will produce glomerular hypertrophy, sclerosis, and renal injury. So that the newer drugs of mineralocorticoid antagonists have helped in preservation of the glomerulus, preventing glomerular hypertension, hypertrophy, mesangial cell expansion, and on the heart, increased coronary vasodilation, nitric oxide, mitochondrial function, and left ventricular perfusion, and of course nitric oxide activation. So that mineralocorticoid is very important for the protection of the whole components of the kidney. Mineralocorticoid antagonist can feel first generation with second generation with third generation. احنا طبعا دلوقتي concerned about the third generation. ليه؟ Very selective for the receptor. The affinity for progesterone and androgen receptors are very low with lesser side effects and hyperkalemic effect, and their role in AKI is very low.
عدينا الوقت بدقيقتين كمان.
خلاص.
احنا ادينا دقيقتين.
دقيقتين وخلاص.
طيب.
last 2 minutes معلش.
معدين انت خدتهم اوريدي.
طيب احنا عندنا في تو ستاديز اللي هي دي كلينيكال لاينز وكانت ليها فيري بينيفيشال افكت في الدايابيتيك بيشنتس في حالات في حالات السكي دي عمل ستابيلايزيشن، وعندنا الاذر ستادي اللي هي الفيجارو دي كانت على الكاردياك بيشنتس وكانت طبعا كارديو بروتكتيف افكت. والاستادي في الحقيقه كانت مهمه جدا انها قللت الكدني فيلر، عملت ريدكشن اوف سستين ديكريز اوف جي فار اكثر من 40%، وقللت الرينال ديث. بالاضافه ديز دراج قلل نيو اونست اي اف والسي كي دي بروجريشن والكارديو فاسكولار هير موربيديتي اند مورتاليتي. وهنا نرجع للرسمه بتاعتنا ان احنا وي شود ان احنا نكفر اول ذيس اسبيكتس علشان نعمل retardation of the progression of CKD patients in diabetic patients, so that there is a great interest to RAAS inhibitors which have cardioprotective and nephroprotective effect. This is in the research and clinical trials, and thank you.
شكرا جزيلا.